A very good morning to all. I'm audible? Yeah. Okay. First of all, let me thank Dr. Selva and the organizing team for this opportunity for me to meet with many of my friends and students here who are doing great work all over Tamil Nadu. And I want to just say we are very proud of all of them. Um, and today I'm talking on my favorite topic. So thank you for letting me talk on that. And for those of you who have worked with me for years, you know this is very close to my heart. Uh, Before I just get into the talk, I wanted to just give an overview of what I will be discussing today. Starting with the Tamil Nadu protocols, what we have. What are the protocols in other Indian states? Then what is the progress in using these protocols, like how we are actually learning from that. Today's morning has all been about learning from data. So I'll share little experience on that. What are the challenges which still remain and what is the way forward? So why do we need protocols? So quite often people say we do have so many guidelines, and then why do we need protocols? Because you know the guidelines, as you know, are those big books which people in public health definitely don't like to read. They run into hundreds of pages, and I think you all have seen those GNC guidelines, and they'll give such complex interpretation, this level of evidence, and so on. And there are a lot of drug classes, and you don't know which drug to choose and how much dose to choose. They give you an overall titration approach. The challenge is, if you are a PHC doctor and you are seeing an OP of 100, 200, 300 patients, and you know, like we know the OPs are really crowded in Tamil Nadu. And in fact, now it's little less crowded due to MTM. I noticed that yesterday. But when I sort of started working in public health, it used to be very difficult to locate the doctor. We'll be hidden somewhere with patients all around. So very hard to expect that doctor is going to use guidelines and actually treat the patient. And hence protocol, something you can stick on the wall and something which you can memorize and actually practice on everyday basis. They are drug and dose specific. So we really need protocols when we take any disease management to scale in public health. And I think it's my career somehow has paralleled the evolution of hypertension treatment protocols, starting from the version 1, which was done in the pilot phase of TNHSP, to the version 2, which was in 2011 to 14. I think this protocol continued to be used for a very long time until there was a recent revision in 2021. And I was actually trying hard to find out that 2007-8 protocol, because I know many people are very young here. They might not have seen it. So this, I managed to find a picture. It doesn't have a full protocol. But you know, this was really the first protocol. And it was piloted in Virudhunagar and Sivagangai districts. Some of you might have been there at that time. It was very interesting because this was the first time that we actually introduced hypertension treatment in primary care in Tamil Nadu. And prior to that, most patients went to either district hospitals or they had to go to the medical colleges. I do remember when I was a student at KMC, and my teacher is also here, Raghunandan sir, we used to have those long queues of patients just wanting to get hypertension drugs in medical colleges, which I hope are not there now. What we learned there was very important lesson that, you know, we can treat hypertension in primary care. I think that was broadly the learning, and we involved nurses. At that time, only amlodipine was in the protocol, 2.5 milligrams scaled to 5 milligram, and then patients were referred to medical college or district hospital even for the second drug. And what we learned that patients never used to go. So we did an evaluation and found that patient never went to the next level, and they continued to be on AMLO 5 forever. And hence we went to the second version of the protocol, which is the one I think many of you might have seen, which has been in use for a really long time, which had 4 drugs at the second level. So if the patient didn't get control with AMLO 5, you could use any of the next line of drugs, which are mentioned here. So this protocol continued to kind of evolve little bit here and there. but more or less has been in use for a really long time. There were two sort of, one was the treatment protocol and one was the screening protocol, which was common for hypertension and diabetes. Interestingly, when I was trying to find these protocols yesterday, I stumbled upon some very interesting photos. I'm sure Dr. Selva will recognize that meeting in 2015 when we transitioned from the TNHSP, which was a project mode, to the program. I think that was a very significant milestone in my opinion, because 2015 national program had not even started doing this, and this was the landmark when we were able to in Tamil Nadu transition from a project to program across the state, and hypertension protocols were implemented all over the state. And these protocols of course stayed on for a while, and of course got older, like both me and Dr. Selva. I can't see Dr. Gerald anywhere today. Okay. And very interestingly, yesterday I went for a field visit and I found this protocol is still there. So one thing I learned, if you do something, be careful before you scale it up. It stays for a very long time. So even when you try to change, it's very hard to change. And I once remember Dr. Kondeswamy, previous DPH, used to say that once it's very hard to start things in public health and it's very hard to stop. Once you start something, it just doesn't change at all. And this was very evident yesterday. Why I'm saying that is because in 2021, this protocol was further revised, and I don't know how many of you have seen this protocol. So this was a simplified version of that protocol. And as you can see, there were 5 steps in this, starting with AMLO 5, going to AMLO 10, then telmisartan 40, telmisartan 80, and then chlorthalidone 6.25. So 5-step protocol, and I don't think it is fully disseminated yet, but I hope that, I know that these protocols were also officially released 2 days back and hopefully should be disseminated more, because people are still using the TNHSP protocol, which are not bad by the way, but I think we need to sort of move on. Now, just shifting the gear a little bit to the national level, see in the last 5 to 6 years, a lot of lessons from Tamil Nadu as well as globally, WHO had what we call as the WHO Hearts package. It was all put together, and ICMR, when I was at ICMR, in collaboration with WHO state governments and some of our international partners, we started India Hypertension Control Initiative, where we were able to introduce these protocols in about 24 states in India. So that was a huge progress, and I really want to acknowledge all that I learned from Tamil Nadu actually helped me sort of work in this. And what we learned in this process was that it was very well accepted in most of the states. And here I'm showing you example of 2 such protocols, one from Maharashtra and one from Punjab. And the reason I picked these examples is, if you can see here, the Punjab protocol, we are scaling amlodipine from 5 to 10 and then adding telmisartan 40, going to 80. But in the Maharashtra protocol, it's amlo 5, then telmi 40, telmi 80, and going back to the amlodipine 10. So there is a lot of literature which says that if you use 2 different kind of drugs, it's better than using one single drug, the higher dose of single drug. So, but we had very interesting observations on the ground, and under this project, we were able to put up a digital system and collect large amount of data over years, and we analyzed this. So this we recently actually have published, and you can read this paper. So the patients who were enrolled between 2018 to 2021 in these 2 states in the project districts, we were able to analyze data from about 3 lakh patients, and what we learned, we took only those who were on protocol, like amlodipine 5 mg. We started, if they were on a protocol, they were included in this analysis, and it was interesting that nearly about 50% continued to be on treatment as on Jan to March 2022. So what we learned from this is the really important slide. 70% are getting controlled just with amlodipine 5, which is very encouraging, which tells you that one drug makes a difference. Now, if you go to the second level, here it is AMLO 10. your control improves, cumulative control improves by about 5%. The problem starts after that. We are not seeing any improvement at all. But that's because doctors are not escalating the drugs. Patient is continuing to be either on one drug or a higher dose of that particular drug. So they are just not going beyond that. And if you look at this number here in the second row, for instance, only 69% got controlled. So the rest should have been escalated to the next level, but that did not happen. And similarly, as you can see, as you go down, the escalation is a real problem. And now, if you go to Maharashtra protocol, and many experts told us that, oh, you should see better results if the second level drug was telmisartan. But we only saw, again, same progress. Although at the initial level, we saw a little bit higher control, about 76%, but the change is only 5%. You get 5% more people under control when you go from AMLO 5 to TELMI 40. However, after that, we are just not making progress. So the point I want to make is that lack of escalation of treatment is a real problem that we need to address. Because even if these patients keep coming back to us, they come again and again, every month or every 2 months, we are not getting them under control. And this is a low-hanging fruit. We are wasting so much energy on screening more people, finding more people, doing all these campaigns. These patients are right there, and we are still not getting them under control. So the takeaway from that is that this treatment, or we call it as therapeutic inertia, is a huge challenge. And we have done many studies in Tamil Nadu and documented it. Also in smaller studies that we did as evaluation of TNHSP, we have seen. Many of our MPH scholars have also documented this. And the second issue which is being repeatedly highlighted is it because of multiple pills? Because patient has to take so many drugs. And is it because of that they are not taking treatment? So first is a doctor problem, second is a patient problem, and third is a system problem. So it can either be a patient problem where patient is not taking drug, or the doctor is not escalating drug, or you are not able to procure and put adequate drug. So I think I'm not going to talk about the third one in context of Tamil Nadu because that's not a problem. But I think the first two continue to be a problem. So going a little bit, reflecting deeply on this issue, the way forward, I think we need to do 4 things. I feel the program in Tamil Nadu is very mature. And we should not be focusing so much on things which many other states are doing, which is like just institutionalizing these programs. We did it in 2015. It is a time for us to really look at quality and outcomes. I think many speakers have talked about that in the morning. So the first really is, are we building enough capacity of our doctors that they titrate to achieve control? Second is, we also have high-risk groups which are in the range of 130 to 139, borderline groups, but they have other high risk factors. Should we be starting treatment for them? Third is really considering a fixed dose combination single pill, which now there's a lot of evidence, and I'll talk a little more about that, can improve control. And fourth and most important is quality improvement initiatives. I think we have done enough of getting programs in place. We should be focusing a lot more on the quality. So the first one, if we talk about, we know the cutoff is 140/90, but I know there are many clinicians sitting here in the audience. How many clinicians really look at the reading and say, okay, it's not 140/90, I should titrate. So what happens in that process is, and whenever I have gone to field, I often hear this, doctor will say, no, side effect will be there. Patient complaint பண்ணுவாங்க. Some reason they will give. I think it's important to understand that the cost of not treating is way higher than those mild side effects, which can be pedal edema, giddiness, and so on. If you're not treating, people are going to either die or be disabled for life due to stroke or heart attacks. So making it very high priority that side effects versus losing lives. We need to sort of weigh the benefit and risk. And the data shows, so this is one of the largest data from cohorts globally, which shows lower the better. So quite often people say, oh no, low pressure vandurom. Low pressure, no one is going to die of low pressure, so don't worry about the low pressure. Worry only about the high pressure. And no matter what ages. The other thing quite often I hear is, patient is older. Why to treat? All these excuses cannot be accepted, because no matter at which age you treat, you save lives, you reduce heart attacks, you reduce strokes. And there are some simple tips that we can look at. One of the most important thing is, again, I mean, there was a lot of digital being talked about today, but I feel patient card was such a good thing we did in TNHSP. If you can't do patient card, you need to have some way where a longitudinal record is accessible to the doctor when they see the patient. They should not be looking at one reading. Quite often they are making their decision based on one reading, which is not a good idea. Because if you see someone has 3 or 4 readings which are persistently high, it's a lot more easier for you to make that decision. Second is, can we ask the nurse to even highlight, use a different color, or just a highlighter pen to say, okay, this patient, they have these notebooks, it has been high for last 3 times. And always make sure that decision, while making the decision, a good history is taken, whether patient has taken medications or not. Quite often they don't take medication the day they come to clinic, but a good history can address that. The next most important issue I want to highlight is, when we do analysis of data, and we have seen in Tamil Nadu also, lot of people have borderline blood pressure. It is somewhere hovering around 140. And people say, oh, it is just 140. But 140 is 140. You want to get it below 140. So please titrate the drugs even if you are at 140. Do not have the fear of adverse effects. And also take into account all their previous blood pressure. Use multiple readings to make that decision. Recently, WHO revised their guidelines. Yeah, I'll be done in 2 minutes. Recently, WHO revised their guidelines, and I'm not going to go through all of that. I would really request all of you to go through it. It's a very good document. They also have a summary. But I want to focus only on the point number 1 and 5, which is, I think, relevant for Tamil Nadu. One is the threshold for treatment initiation, and second is the single pill combination therapy. So why it is important is that we, as a state, Tamil Nadu has a very high burden of diabetes as well, in addition to hypertension. And there are large number of people who are at high risk of heart attack and stroke, and we have very high cardiovascular mortality. We all know that. I don't need to sell this to this audience. There is this group of patients with blood pressure between 130 to 139 who either have had a previous cardiac event, or who have diabetes, or they have chronic kidney disease. These patients need to be brought under treatment, because we can save lives by doing that. But this, currently we are not doing it in our protocols, but we need to think how this can be introduced. So changing our threshold for high risk group. The second most important thing I want to talk about is combination therapy. Now, in the recent years, few other states have actually now included combination therapy in the protocols, and we need to see how it works. Cost has been an issue, but if you procure at scale, the cost will come down. It reduces the pill burden for the patient, but most importantly, we have a lot of data to show that it is very effective. Now, these are the commonest drugs used in these combinations. You have diuretics, ACE-ARB, and long-acting calcium channel blockers. And the combinations like amlo-telmi or telma with one of the diuretics are extensively used in private practice, and it is actually the commonest prescribed drug in India. So, where it will work? So, as I showed you in our data, that people, 70% get controlled with one drug. So, let's not worry about that group. Now, what about the other 30%? For those 30% is where we should consider a combination therapy. By using a combination of amlo with telmi, rather than giving them 2 drugs, can improve compliance and can improve control in a very big way. So one of the things we have been looking at and have discussed with many experts is, people who are coming in the blood pressure 160/100 and above, they can directly go on combination therapy. So rather than putting them on amlo 5, you directly put them on combination. There is a lot of evidence that it works well and there are no adverse effects. Dr. Raghunandan is here. He mostly heads all the protocol committees. I request, sir, you can look into this possibility. And we can also document in a small research to see if it is improving compliance. Because the data shows there is 8 to 15% improve in compliance. And there was a very recent analysis I read from a very large non-randomized trial in Italy which showed that there was 20% reduction in mortality for people who went on combination therapy versus who were on a single pill therapy. And the last point I want to make is quality improvement. I think I have seen under the TNHSP, many quality improvement initiatives were brought in mostly for hospitals. But I think it's time that we bring quality improvement initiatives into primary care. And there are many models of that. I'm not going to go into detail of it, but I want to leave with this idea that we should develop a quality improvement initiative for the NCD program for the state of Tamil Nadu. Recently, we have done some pilots in some of the other states. So basically, what does this quality improvement, there's one of the ways focus PDSA, where you identify opportunity for improvement, you organize a team, you clarify the process, you do the root cause analysis, and then you try to address. And one example I have shared with you is already the treatment inertia, therapeutic inertia, which can be addressed through this. Gopi is here, he has worked on that in Karnataka, and I think now he's come to Tamil Nadu, maybe he can help write a protocol for that. I think this can be piloted, and this was a small study we did in Madhya Pradesh, where we used this focus PDSA cycle approach to improve follow-up in a setting where the follow-up was very low. And as you can see that after introducing the QI approach, the follow-up has gone up. Want to acknowledge Dr. Rupali who worked on this. But I'm really happy to support, but I think this is something we should do, introduce more and more QI initiatives. And just to conclude, I just want to again say what speaker said in the morning, please analyze your data. We need to really analyze our data, at least in few sites, to understand if our protocols are working or not. Document therapeutic inertia and also see if we can build capacity for that. Consider adding combination single pill for people with blood pressure above 160/100 and implement quality improvement initiatives. Thank you again for the opportunity.
Thank you, madam. Nice presentation. You enlightened 3 phases of hypertension protocol, as well as you compared the 2 states implemented the protocols, the Punjab and Maharashtra. The patient side problem, that as a doctor, we are only concentrating on screening and prescribing drugs. You have to give more focus on primordial prevention, that is lifestyle modification, as well as health promotion activities like exercise, morning exercise, light exercise and walking, and low salt diet. Like that, you have to more emphasis as a primary care people. We have to give more important on lifestyle modification and simple exercise. Then second is the capacity building, the doctor problem. The doctor should know the anti-hypertensive like all classification, what is the advantages, disadvantages. We are mostly recommending AC inhibitors, ARB, angiotensin receptor blocker, as well as calcium channel blocker, and long-acting calcium channel blocker they are prescribing, and the diuretics also, that is thiazide diuretics. The usage of diuretics, we have some negative problem also, that electrolyte imbalance something we have to take care of. But anything, you have a regular PAC visit, follow-up, that is very, very important. If anything wrong, please refer to nearby secondary care hospital and tertiary care hospital for physician opinion. That's second. The third, the system will take care of availability of all drugs. Thank you, madam.
Sir, just a comment. Madam, you rightly told about the experience of Maharashtra and Punjab. With monotherapy, you could achieve around 70 plus
70%,
other things and all. So when you are doing a public health program of this kind, with this kind of thing, what is the expected target control we are expecting? Is it 100% may not be achievable, but what is the expected level of control that we can expect out of this program? And you nicely addressed the patient-doctor system. I think all the 3 has been addressed in Tamil Nadu. Today we have a MTM, so
Yeah.
availability, ensuring the thing. Maybe
Right.
we have to focus, as Sir was mentioning, about lifestyle modification. Also, I can add to that thing. And also, we have hub and spoke model where the patients can be referred if
Yeah.
that thing cannot be controlled. And final thing, have any study done in Tamil Nadu on this? Same as Punjab and Tamil.
I think I'll answer the first one. So I think it depends what denominator we look at. If we look at all patients under care, what we find is achievable is about 80%. So the problem is we are somewhere hovering at around 60%. This 20% is the one which is due to therapeutic inertia, which we can address. There are about 20% patients who keep going in and out of treatment and we can't address that. But if we look at patients who are continuously on treatment and coming back to us, I think we should be more than 90%. The problem is with that group, and we are not achieving control even in that group. So, and I want to acknowledge, sir mentioned about lifestyle. I actually didn't talk because I know after me there is a speaker talking on salt. So I have decided to stay away from that to avoid duplication. Yes, salt related dietary changes and low sodium salt are important interventions which we should consider as an adjunct. I want to make that point. It is not a replacement for drug therapy for patients who are diagnosed hypertension. I think there is a misperception. People sometimes think lifestyle is enough. Not if you are above 140/90. It is okay if you are a pre-hypertensive. So, and yes, of course, sir, we can discuss more on further on this combination pill and experience on these protocols. Thank you. Any more questions? Otherwise.
Thank you, ma'am. Now I request Dr. Senthil sir, Joint Director PHC, to felicitate the speaker. Thank you.